Hello friend, this is a case of total laparoscopic hysterectomy, and this patient has adenomyosis and there is a fibroid in the posterior wall of uterus with severe AUB, abnormal uterine bleeding. So we will do the total laparoscopic hysterectomy, but before that we will do cystoscopy and we put infrared ureteric catheter. This is cystoscope with a beautiful blunt tip, and there is a fiber optic 4 mm telescope attached. So cystoscope has the blunt tip that is atraumatic, and this is ureteric ridge. We can see this is the left ureteric orifice, and this is the soft end of the fiber optic. This is the guide wire we will introduce, and the 15 centimeter of the transparent 6 French ureteric catheter is introduced. So we can see this is 3 line, that means 15 centimeter, and this is left side of ureteric catheterization is over. After that cystoscope is out, and then we will reintroduce with the another ureteric catheter, and we will go, and this is the right ureteric catheter which will get catheterized. So this is ureteric orifice, little bit rotation is required sometime to dilate the ureteric orifice, and then this is the 6 French ureteric transparent ureteric catheter is introduced into the right ureter, and again we will go up to 3 thick line so that 15 centimeter will be calculated. This is 10 centimeter, and now this is 15 centimeter. So it is over. Now we will take it out and we will start doing. This is the uterine manipulator. This is Mangeshkar uterine manipulator which will be introduced. This is the fulcrum of uterine manipulator, and we are using 3.5 centimeter colpotomizer with the tenaculum, and that will be introduced, and the uterus will be anteverted and contralateral traction. We can see both the ureter is nicely visible, and you can have a look, and anteversion of the uterus will be carried out. Uterus is little restricted, but we will perform the surgery by the 3 port only, and 2 working instrument, 1 telescope. So this is round ligament that is 4 centimeter lateral to the uterus which is coagulating, followed by fallopian tube that is approximately 3 centimeter, and uterus has a contralateral traction. It is getting pushed towards the 9 o'clock position, and this is ovarian ligament. Now this is mesosalpinx and meso-ovarian, and ureter is down, much down as you can see, and then we will go 2.5 centimeter over the broad ligament. So now after this further we will not go further. You should only go after opening the anterior and posterior leaf. Now uterus will go at 3 o'clock position, and this is round ligament getting coagulated, followed by fallopian tube, and then you will get mesosalpinx, and then this is ovary, and then this is ovarian ligament. After that 2.5 centimeter over the broad ligament. The left ureter is also, as you can see, it is blinking, and it is blinking up to the bladder. You can see on the top it is going up to the bladder. So this is left side of dissection is also over. After that uterus will be retroverted at 5 o'clock position, and will start separating the anterior leaf of the broad ligament. So this is uterus is cranially pushed as much as possible by the help of the colpotomizer, and it is retroverted. And after that left hand will stretch the peritoneum, and right hand will cut the peritoneum over the anterior leaf of the broad ligament. This is of the left side, and harmonic is the good instrument here because it can break the hydrogen bond and it can make its own plane of dissection. Like I showed you, is not good to cut the peritoneum, and assistant will keep on slowly separating the and doing the rotation of the uterus from 5 to 7 o'clock. So this is the anterior leaf of the broad ligament of the right side is getting separated. We can see ureter is going down, and this way you can push the ureter further lateral, further down. So this is one of the way. Even if you don't have ureteric catheter, this way you can minimize the injury of ureter. Now this is little adhesions are there on the bladder anteriorly. So at the level of UV fold, this is the harmonic which is little bit separating the bladder, and now bladder will be separated. Sometime if there is a previous cesarean section, this type of adhesions may be found, and then you can make a lateral window and you can separate the bladder pillar. So this is separation of the bladder from the pearly white vaginal fascia with the crisscross pattern, and then you have to do the lateralization of the bladder pillar is required, so that when you take the uterine you will have the proper hemostasis. And this is 3 cm at least the bladder should be separated. Sometime if your bladder pillar is thick, you may use the harmonic to cut it and then lateralize. This portion of the lateralization is very important to prevent the injury of ureter. So this is important step, and this way you can push the ureter further lateral. So we can see ureter is going further below. You can see the light of ureter, and which is getting. Now again we will separate the bladder pillar of the right side, and further lateralization of this will be performed. So this is a important step to to minimize the bleeding of the uterine artery, because if it is this area is thin, you have the proper pressure over the ligature, and you can do proper skeletonization, and you can do the hemostasis. So now it is over, and this entire bladder is separated. After that, we will put the uterus at 1 o'clock position, and this is the posterior peritoneum of the left side. Left hand is very important because left hand will keep the peritoneum stretched, and we will go from above the arc of uterosacral ligament. Uterosacral ligament will not be cut. Here it is just separation of the peritoneum. This step is separation of the peritoneum. Uterus is at 1 o'clock position. Now uterus will go at 11 o'clock position, and this is right side of the posterior leaf of the broad ligament will be separated, stretching by one hand and then cutting by peritoneum, and only peritoneum. You should not go deeper, otherwise uterine vein can start, and knocking effect of harmonic will puncture the vein, and then bleeding can be there. So this is slowly separating the peritoneum, and you can see ureter is lateral, that will be further separated by pushing it down. So this step will do the further lateralization of the ureter and pushing it down. So this is done. And it's over. This is the 2 uterosacral ligament. Generally we go above the arc of uterosacral ligament. Now this is uterus is again at 3 o'clock position, and we will coagulate the uterine artery of the left side, but this will be only coagulated. What is our strategy generally? That in first time we don't cut, we coagulate and leave it, and then we go to the right side again coagulate, and we cut later in the second time. So that has advantage that proximal thrombus also will form, and proper hemostasis can be achieved. So this is done, and now this is the right side of the uterine artery which is getting coagulated. We always apply little betadine in between the jaw of the ligature, so a sticking effect will not be there, and you can see the good bubbling effect. A sticking will not be there, and if a sticking is not there, then you have the better coagulation, because if temperature will never increase more than 100 degrees centigrade. Now this is second attempt. In the second attempt again, this time we will coagulate as well as cut. So this is now again ligature is coagulating and cutting. Again this is a little bit Macan rod, that also you can coagulate and cut. So this is the left side is done, and the uterine is secured, is over. Now again contralateral traction will be given, and this is right side. So this is the right side of uterine artery getting coagulated away from ureter. Laterally ureter is visible, so it is safe, and it is coagulating here and cut. So then little bit Macan-Rot also will be cut, and this side is also good. So this is only 3-port surgery, that's why this side is more difficult. Ideally the beginner should do 4 ports. So for the right side, their port instrument should come from right, so that their tip of the instrument would be medially placed. And now here we will start colpotomy. So this is starting from 6 o'clock, and then above the arc of uterosacral ligament, this is colpotomy started. And slowly your assistant will rotate the uterus, and with the vibrating jaw of harmonic you can do colpotomy, keeping it very carefully and stable. So this is now anterior. This is the anterior colpotomy, and similarly we will go to the right side. So this is slowly over the white part of the colpotomizer. This is anterior colpotomy. And now this is the right lateral colpotomy. And now this is posterior colpotomy started. This is right lateral colpotomy. And this is posterior colpotomy. So hysterectomy is over, and now uterus will be pulled out. If you want, you can remove the tube or ovary, it is optional. Some people, they are not in favor of removing the tube because it increases the devascularization of the ovary, but this is up to you. Now this is uterosacral ligament. This is the right uterosacral ligament, posterior leaf of the, and this is anterior, and epithelium, as we know, must be included, and this is anterior leaf of the vault. So this is anterior and posterior vagina bite is taken, and then we will do the continuous suturing. So this is 3 bite only, one on the one uterosacral, then another on the middle, and it is little everting is bed, good, so that there will no granulation tissue formation. And now this is the 3rd uterosacral ligament of the left side, and again anterior vagina including epithelium. So once this all the 3 bite is taken, and this corner it is better to lock. So you will go with the loop and you can lock it. And now once it is locked, then you can start returning back with the same suture. It is returning. So only 3 bite is taken. The first layer it is continuous without locking, and the second layer continuous with locking will be done. So this is going now returning back with locking. And this is the last bite on the right corner, and this also is locked. After that, with the tail, starter tail, we will terminate it here. Little suction irrigation will be performed. So hardly 5 ml blood loss is there. We have not used suction irrigation any time during surgery. At the end, just little bit it was performed, and now it is terminated and needle will be taken out. So it is a very simple case of the hysterectomy for abnormal uterine bleeding. So thank you very much for watching this video. This is just a final suction irrigation which you can carry it, and you can inspect all around, and after that ureteric catheter will be taken out. So the tip of the ureteric catheter is already outside the urethra in this situation, so just directly you have to pull it. It doesn't require again cystoscopy. So this is over. There is no bleeding, everything is dry. So thank you very much for watching this video. Have a nice day.